about limited blood flow and accumulation of iron in that. What about talking a bit about what could cause the limited blood flow? Is it events or conditions that makes these restrictions?
Can you repeat it again, please, sir? Hold the mic a little closer.
Okay, the limited blood flow, what causes those restrictions? Accidents or medical conditions?
Well, you know, as I alluded to it at the start, the number one feeling when I read about it, you know, refreshing it even as recently as yesterday, is that most of these things were born with, meaning that as we were formed in the womb, there was variations in how the veins were formed. There is a second school of thought that feel it may be partly developed in yourself over time. Perhaps in some of us, when we turn our heads to the side, like I've had a number of ultrasounds now, one of them suggested that if I turn my head to the left to 45 degrees, I shut off that side of the jugular vein, okay? That happens in some of us, one side or the other. The feeling is that when you're doing that, say you're doing it during sleep, so now you're doing it for not just minutes or a moment, you're doing it for hours. What probably is happening when you're creating a partial blockage, you may be creating a lack of blood flow to a tiny part of the vein. So now it gets a so-called ischemic injury and now creates a scar. And as that scar gets more dramatic over time, you may be actually creating a scar so that it's not even normal flow in the midline or on the other side. So those are the two schools of thought of how this occurs. I really don't have any other supposition as to other methods. It can happen with injury. I've got one good friend with MS that probably it was aggravated by their accident. They were at a motor vehicle accident. Okay. So we have known forever, well, 20, 30 years at least, maybe Dr. Hewitt can comment on that, that if you get an injury to the soft tissue of your neck, or if you have throat cancer surgery to your neck, then you are a sitting duck. I watched one case occur in a city in Canada just on the ultrasound side, and this was someone who had had neck surgery, but they do the neck surgery often through the front. And her whole MS went straight downhill after that surgical approach through the front. Obviously, in the scarring down that happened in the healing after, there was injury to the flow in the vein.
Yeah, this question is for Dr. Hewitt. You may have sort of roundabout answered this, but I'd like to, ask you directly. When you use a larger balloon, is there any chance of exploding the vein or ripping the vein? And is that possibly why these other places use smaller balloons?
There is always a risk of exploding the vein, as you put it. We like to call it extravasation in medicine. It doesn't sound quite as bad. In actuality, when we're approaching these valves with this large vein, we're actually trying to do damage. We're trying to tear that valve open, because that, we found, is the real problem. And so there is a chance that when we tear that valve, that a portion of the adjacent vein may tear as well and open. That's one of the known risks, but it really doesn't have any severe consequences. The low pressure in the venous system doesn't lead to a significant amount of bleeding, and we can quite quickly tamponade. Tamponade is a word meaning to stop the blood flow. We just keep that balloon up for a little while. We tamponade the area where the blood's leaking out of the vessel, and we've had no problems doing that at all. No serious complications at all. That may be the reason why they use smaller balloons, but in our opinion, that leads to inadequate treatment.
Just before, I think it's really important because a vein is incredibly distendable, and it's at very low flow of pressure. Okay, so, and I think it creates one of the issues that I believe the neurologists have. They're often thinking of angioplasty in terms of the heart, because that's where we've been doing it for 30 years. I was in Calgary when they were doing the very first coronary angioplasties in the mid-80s. And everybody thought they were crazy, of course, but no one else in the country was doing it. But there's a risk when you're in an artery. If you make a small tear in the wall of the artery, then you will shut down flow through that artery because it gets blood in behind it because of the higher pressure. And then you have to go to emergency coronary artery bypass graft. This does not happen with veins because, as he said very well, we're able to either block it off or we're able to put pressure on it. But we can solve the problem. We don't have the deadly consequences that people suggest because they are thinking about the arterial problem, not the vein problem.
I just wanted to add something from a patient perspective, because I'm not a doctor. But I know that from my procedure, and I think because Bonita and I had it actually done the same day, so we had some similar procedures done. But I remember when I had the ballooning on my left jugular vein, which was stenosed 80%, they actually ballooned it for 2 minutes on my left side. And that's when the anesthesiast was rubbing my head saying, "This is gonna hurt, sweetie." So it was 2 minutes that they used it because they wanted to keep it open, and they do use the bigger balloons in Cabo as well.
Yeah. I don't know, I think my imagination might be getting better. How long are those stents? And if you put them in your leg and you move around all the time, what happens to those stents and can they actually break?
The stents, if we have to put a stents in, the stents typically vary in size anywhere from about 10 millimeters in diameter up to 20 millimeters in diameter. They're very flexible. Most of them are made out of a material called nitinol, which is basically a titanium compound. It's very safe. Stents were originally designed to be put in your liver, believe it or not. So all of the stents we've used, these are the same stents we use in veins. We've been using them for decades, quite honestly. Can stents fracture? Yes, they can. Stents can fracture if they're placed under enough fatigue numerous times. We have not found any problems putting stents in. I haven't seen a stent fracture myself actually in a number of years, putting them in a variety of venous locations. It's not to say they can't fracture them.
My interest is in what happens after the operation. That is, does each place, Bulgaria, wherever it is, have the same follow-up? If I have the operation, would I need to go back, or what is the follow-up?
That's the $1 million question. Yeah, I mean, that's what's been on the news in the sense of people are having difficulty getting follow-up from their GPs, from referrals to specialists, etc. I'm very lucky. I haven't needed any follow-up, but my GP is completely on board with all of this, and so that's the thing about having a great family doctor to have them on board, because they're certainly going to help out the procedure. I can't speak for every facility who's doing the procedure, but I know that they all have sort of different requirements. They all pretty much want you to come back, but we all know how much that's going to cost to fly back to India, to fly back to Cabo, to fly back to Florida, wherever you went. So that's the difficult part of that. So really, they can tell you whatever what kind of follow-up they would like you to do. Whether or not you can afford to do it is another question. And that's one of the issues that that we're dealing with right now in Canada is how do we get that follow-up care? And I think when Sandra was talking earlier about the November 26th session with Dr. Christy Duncan, who is the federal MP who's been going to bat for us in the federal legislature, I think that's going to be a really important thing for the roundtable discussion. And I think it's a really good question that we need to keep asking everybody.
Okay, I just have two quick questions. The first one is the stents that you put in, or that any of the sites may put in, are they all compatible to have follow-up scans? I know that some stents aren't safe for MRIs.
Okay. Yeah, the stents we place are safe for MRIs.
And the other question was the percentage of people that are the healthy population that have these stenoses? It's something around 20%. What is the reasoning behind that existence? Is it because the other routes of the blood takes, does that compensate properly, or what is your theory behind that?
So your question is, what about the 20% of the population that are so-called normal and have CCSVI? Why don't they have an issue? Well, you know, we're probably in a continuum, but let's talk about multiple sclerosis first, because that's one of our focuses tonight, all right? Certainly an autoimmune entity happens in multiple sclerosis. But what is the first triggering event? The first triggering event may be CCSVI, okay? That's one end of the spectrum. And there's probably a piece of the spectrum of folks with MS that are super susceptible and get a lot of autoimmune diseases. You know, whether it's an arthritis or a lupus or a psoriasis and all these other things. So that's the spectrum where the autoimmune may take off on its own. So these people may not have CCSVI. At the other end of the spectrum, you've got the folks that CCSVI is the biggest deal, okay? It seems to create most of the symptoms of the MS. And then there's probably a continuum between those 2 points. And we don't know where each of us falls. So that's what I would suggest is the entity. Now, the folks that are so-called normal flow, we will learn more over time, especially when we start doing venous flow. It's a year ago now, I went to Edmonton to see my neurologist colleague who is an expert in stroke, because he and I used to research stroke together in Saskatoon. So I had ultrasound of my veins done in his stroke clinic. A very good ultrasonographer. My veins were read as completely normal. But that was the very first vein ultrasound that person had done. So we haven't been thinking about CCSVI at all in medicine. It's a brand new concept, maybe 2-3 years old. Even though Dr. Zamboni's been thinking of it for a long time and studying pieces of it, he didn't move forward dramatically until his wife was involved, okay? So we will start to look at more of these, and we'll start to follow these people, and we'll start to be aware. Maybe some of that 20% are the ones who are more prone to Alzheimer's, or more prone to Parkinson's, or some other entity, maybe even ALS. We don't know. But that's what we won't have any idea until we have been looking at folks for a while. Because in medicine, you can't make an interpretation until you're able to follow it over time and gain the experience to do it properly.
There's a question at the back, and then we'll go to.
Yes. What are stents made of? And how do they affect people who are allergic to nickel if they're made out of nickel?
There's a variety of different materials that are used in different types of stents. Most of the stents we use now are made out of amalgamation called nitinol, which does contain nickel and titanium. And very rarely we do find people who are allergic to stents. It's been about 7 years since I've had someone who's allergic to them, but it does occur very rarely.
How can you tell they're allergic?
You know, allergies come in a lot of different forms. This person got a lot of pruritus, which is a fancy medical term for itching.